Good morning, everyone, or afternoon, and thank you all so much for your attention and for inviting me to present on this topic. I think it's an incredibly important one. So I'll be talking about the trauma of the opioid crisis. I am a addiction medicine and family medicine doctor, and I work at St. Joseph's Hospital, so part of the M Health Fairview system. Oh, okay. Just learning how to advance in real time here. First, my disclosures are that I'm employed by St. Joe's, so I don't receive any other funding, no sources of rubles or dollars. And although I am the president of ASAM in Minnesota, I'm not speaking on their behalf today as part of this. So the objectives here are to understand the epidemiology of the opioid use disorder epidemic and traumatic psychopathology, understand what may underlie these diseases and how they relate, and explore what we can do about it. So hopefully we'll end on a hopeful note, even though this is a little bit of a grim topic. First, just a little bit of review. Opioids and opiates are things that activate the mu receptors in your brain. Opioids are anything that does that, and opiates all come from the opium poppy in some derivation. So usually I do this in person, so it can be a little bit more interactive, but hopefully if you're as nerdy as me, this is an easy one. This is Morpheus, who is the god of dreams, and that's what morphine is named after because of the euphoric effect that it has on people. Just some more sort of review of opioids, and that's a lot of detail that I just include for your reference in the future. I'm not going to really read over all these slides. So just a reminder that this opioid crisis that we're having now is not a new thing. Bayer's, which makes aspirin most notably now, actually developed heroin in 1890 and sold it originally as a non-addictive substitute for morphine as well as a cure for the cough. And it does actually cure coughs really well to stop you from breathing. But we stopped prescribing it for those purposes for obvious reasons. But just one of the historical facts about just how much our treatment standards change over time. There also has been a correlation between increased opioid use in society and societal harm. So in the Civil War, there was a huge loss of life, obviously. And at that time, a lot of people who were traumatized by that turned to the use of morphine, which they could be prescribed by their doctor and then use in their home. And it was very prevalent in the South and worse in women. And this was often even something that would be given as something that could be used as an injection that doctors would bring to people and leave at their bedside. So there's fascinating history there. It's very clear that this was something people were using to stop the pain that they were in. So then,
Dr. Brunner, there's a question. Could you explain what iatrogenic means, please?
Oh yes, and thank you, because I often use a lot of big words and so thank you for bringing me back down from that. So thanks for that question. Iatrogenic means doctor induced. So essentially doctors were inducing morphinism in people at that time by giving them heroin and morphine to treat their issue of basically depression or anxiety, with obviously not great results. So then to fast forward to another traumatic episode in our history of Vietnam, At that time, there was a lot of IV heroin use, well overseas. In fact, almost half of the general service members in Vietnam tried heroin or opium at some time, and about 1/5 of them developed physical dependence. But when they were, so there was a lot of concern in the US and preparation for how to treat the soldiers as they returned from Vietnam. However, a surprising finding was that a lot more of them were able to attain meaningful remission. So about 2/3 of them at 6 months were no longer using at all, which is very different from the general outcomes that were seen in other patients who did not start using in Vietnam under that situation of extreme trauma. So it really shows the interplay between trauma and addiction, and how sometimes when those traumatic events go away and you heal from them, sometimes the addiction does as well. So this is the main, if you remember one thing from this, because research shows you're probably only likely to remember about 3 things from my talk. So I would argue that one of them should be that, you know, in 2015 to 2017 in the US, life expectancy declined due to drug overdose, suicide, and alcoholic liver disease. Just a crazy, startling statistic. Oh, it looks like maybe there's a question. All right.
Nope, nothing yet.
Oh, okay. So I'll stop trying to do that part myself. So then in 2018, life expectancy did rise slightly, but not quite as meaningfully as we would hope. But that is a little bit hopeful. The last time life expectancy declined in this manner was from 1915 to 1918. And I really have to fix this. I had this last time too. It was actually World War I. And the 1918 flu pandemic were the cause of that decline in lifetime expectancy. And it's a little bit eerie because I put together this talk and slides before coronavirus was ever even a bat in my radar. So the whole epidemic playing out now is a little bit extra frightening for this reason. Another thing that's interesting, and this is not any kind of scientific fact, but is that this drop in life expectancy also occurred right after the 1914 Harrison narcotic act. But that was really the key piece of legislation that stopped physicians' ability to provide maintenance treatment for opioid use disorder in stable patients. So there's no proven causal link, but at that time, physicians warned that because they would be no longer able to provide ongoing maintenance therapy, they really expected a bump in death, and really saw it in those patients. There's no proven causal link, like I said.
Dr. Brunner?
Yes.
We have a question. Peter asked, does that mean when using traumatic therapy with someone who is also using an opioid, you should emphasize treating the trauma primarily and the substance use secondarily?
So I would argue for treating both at the same time, and I think that's really the current standard of care. And a great question that previews, we'll get in towards the end of the talk, just trauma-informed treatment and working along that approach. But really that both things need to be addressed simultaneously for meaningful recovery and also for healing from the trauma. But that if both things aren't addressed, and I should say here too that I'm not a psychiatrist, I'm an addiction medicine doctor, so I always really rely on my excellent mental health partners in this arena. But I do try to always get them engaged and helping me, because I try not to unroof the trauma myself, because I'm not qualified to do specific psychotherapy on that arena, and I don't want to cause any harm. This is an editorial from 1915, just highlighting, as I said, the physicians were warning that they thought that there would be a real impact from the Harrison Narcotic Act, that because they would no longer be able to provide safe treatment for people, that they would turn to criminal ways of obtaining narcotics, which was seen, and kind of previews a lot of the conflicts that patients continue to have and the trouble they continue to have with accessing meaningful medication and treatment today. Deaths of despair was a term coined by the Brookings Institute in 2015 by Ann Case, and I'm blanking on the other person, but there are two people, so I apologize to that person for not giving full credit, but really aimed at drug overdoses, suicides, and alcohol-related deaths, all of which have been increasing significantly, especially in the middle-aged white male population. This is a little bit complicated of a slide, but it shows how basically on the one side that for the US, mortality has been climbing with worse life expectancy outcomes, especially in this middle-aged white male population, so 45 to 54 age group. And at the same time, the mortality rate has been dropping in other countries with different forms of medical care and societies. And then just to look at the causes of the death, lung cancer, which used to be one of the big predominant drivers of death, has actually been decreasing. Diabetes has remained relatively the same, as you can see. And then there was the huge spike in drug overdoses, with then a more minimal spike in liver disease and suicide, but still concerning. This slide breaks out the 3 waves of the opioid overdose deaths that have been identified so far. Now people put on a 4th wave too that I'll talk a little bit about. But just a shocking number from 1990 to 2017, over 700,000 people have died from drug overdoses. And in 2017 alone, that included over 70,000 people, with over 68% of those cases being an opioid. That was 130 Americans per day. So the first wave seen was the rise in prescription opioid overdose deaths, followed by a rise in heroin overdose deaths. And then the more recent thing we've been seeing is a rise in synthetic opioid overdose deaths. And those include primarily things like fentanyl or other things like carfentanil and other similar drugs that are made to try to avoid being identified and to be then sent through the mail. The 4th wave I was talking about is mixed drug overdose deaths, which are being seen more, so including more stimulants, methamphetamines, cocaine. We're especially seeing a lot of stimulants in the Minnesota area. Every year, 2% of the 2 million Americans who have opioid use in the US are killed. So it's an incredibly lethal problem for something that affects mainly younger folks. And this is some of the people who have been affected. I usually ask if anyone knows who these are. So again, a little bit different than my usual style, which I like to be able to interact with people, but that's okay. So Anthony Bourdain, Kate Spade, Robin Williams, and then this is Alan Kruger, who basically saved the economy.
Dr. Brunner, we have another question. Alex
Oh
says,
yeah, sure.
sure, thank you. Alex says, I've heard the opioid epidemic compared to the crack problem of the 80s, and that we're paying more attention to opioids because it affects white men instead of black folks. Do you have any thoughts on this?
That is a fantastic question, and I think it's entirely true. I think it just is undeniable that we are paying more attention for that reason as a society, and that's not okay. There has been a shift in the opioid epidemic, and it's a little bit over the scope of what I was talking about today, but we have seen it move from primarily affecting Caucasians to really affecting more African Americans, and also with them having less ability to be prescribed and have access to treatment, especially to Suboxone treatment. So it's been more lethal for that population as well. So there has been a shift that has been disheartening and unfortunate. And so I wish we could solve that disparity problem. So I think that's a really excellent point. To move on to suicide, suicide has also been rising progressively and gets a little bit less attention, but still one person commits suicide every 12 minutes in the US. It's 44,193 people in 2017. And only about half of those people have a known mental health diagnosis. So factors that make it more likely to commit suicide without having a known diagnosis previously would include generally being male and of older age, and to die via use of a firearm. This has been actually a particular problem in Minnesota, and in 2017, suicide was the 8th leading cause of death in Minnesota and accounted for 783 deaths. It's not just suicides. For every suicide, there are also 9 adults treated in the hospital ER, 27 making suicide attempts, and over 227 seriously considering suicide. I wanted to inject some good news here. In 2018, there was a 5% reduction nationally of opioid overdose numbers per the CDC, and a life expectancy increase of 0.1 years. So finally, some movement in a good direction. Unfortunately, suicides still increased by 1.4% overall, with a larger increase for men than women. In Minnesota, overdose deaths declined very significantly from 422 in 2017 to 331 in 2018. But there was still significant racial disparity in access to treatment, and Native Americans were 6 times as likely to die of a drug overdose as Caucasians. We also have been seeing a rise in methamphetamine deaths that was pretty significant from 2017 to 2018. I wanted to include this view of Star Wars land because I thought that it was getting pretty depressing, and it makes me smile. So I hope everyone here likes Star Wars. Seems pretty much like a safe bet. This slide is just intended to remind us all that there's a ton of overlap between mental illness and substance use disorder. So these diseases do not occur in isolation by any means. And that in general, the substance that actually is most associated with suicide is not actually opioids, but alcohol, which is present in 38.2% of people tested after a suicide, with the next most, I would argue that it's good if antidepressants are there, so that I think is not so concerning. But then there's pretty significant association of benzodiazepines as well. There's huge gaps in patients obtaining enough treatment. So of the 19.7 million people who have a substance use disorder, 92.3% of them are not receiving treatment. And in the people 3.2 million people with both substance use and acute mental illness. Less than 9% are being appropriately treated. Just another factor that's obviously something that we're all thinking a lot about now is the coronavirus. And the death toll from this recently has been spiking to recently being the #1 cause of death in the US. So I just included that too here because this is going to be an obvious source of trauma for people. There's a chicken and egg phenomenon with opioid use disorder and trauma. So patients with opioid use disorder experience trauma, it leads to relapse, mental health disease intensifies, which can cause more trauma, which can cause more relapse. And so this can be like a circling experience where these two things really reinforce each other. So now just to shift gears to get into the factors underlying the development of all this stuff. As with all chronic diseases, there's an interplay between nature and nurture. So first, just the most basic thing is going back to Maslow's hierarchy of needs. We all need food, water, rest, and security. And if you don't have those things, you're unlikely to achieve, self-actualization and really be able to spend a lot of time meditating upon your sobriety. So I think that's something important to remember when we're treating patients who have a lot of baseline social issues, that we can't ask more from them than is possible, and really need to meet them where they're at and think about what is actually possible. These are just a view of the underlying causes cited in cases of suicide. And many of these factors are also present in cases of opioid use disorder. Obviously, in 28% of them, it looks like substance use was a direct cause of the suicide, and then legal problems, relationship problems, loss of housing, crisis, all things that certainly contribute to relapse and opioid use as well. And then just like in politics, in trauma and opioid use, there's a lot of economic factors at play as well. So there are studies from the US examining historic trends that show that during economic recessions, there are increased suicide rates, particularly for working age individuals of 25 to 64. And economic strains can also cause increased risk for suicide as well. We currently have like a massive inequality in wealth going on, with a lot of people terming it the second Gilded Age. I would call it like the private space age, since we have multiple billionaires who are funding their own like spaceships. So this is just a picture of Elon Musk's Tesla circling the Earth, because he launched that for reasons of being able to feel glorious that his car is circling the Earth, which is just a very good, I think, exhibit of how different of circumstances we all have, that he has the money to do that sort of just on the side. There's a lot of chronic low-level stress going on in work situations right now that is a new phenomenon. So there's a rise of a gig economy with less of the ability to feel like you have an ongoing relationship with your employer. In general, people are not able to do as well as their parents for the first time in the US in generations. Wage growth has not been occurring for most people. And we have algorithms on all of our computers that basically keep us looking at things that we have liked to look at in the past. So that makes a filter bubble where we're all seeing things we already believe. So just reinforcing our own narrative and kind of differentiating us into little groups. Wage inequality is continuing to grow, as I talked about in the private space age, but another startling fact is the 62 wealthiest people in the world have the same amount of wealth as the bottom 50%. So there's analysis that now we actually have more wealth inequality than we did in the first Gilded Age by a pretty significant percentage. Jobs have changed, so you can't really rely on starting a job and knowing that you're going to retire from it anymore, because there's so much change in the workplace, and there's this rise of this mentality of we're not a family, we're a team and can all be replaced. So this is kind of an interesting story and slide deck, but Netflix actually had a huge influence on not only entertainment, but also the workplace, because they came up with this culture slide deck that influenced a lot of other places around the country to change the way that they hired people and kept them on. And it was all started by a woman who put it together and worked for Netflix for 12 years. And then she got fired and moved on. And she didn't like that so much when it happened to her, despite her promoting that anyone should be happy to move on at any time, because companies are like a team, and you should just be happy if you're in a role that works for you, and if not, you should just be happy to move on somewhere else. And that's not really how humans work generally. Loneliness is a huge factor in our society today, and that actually has a very strong effect on physical health. There's a really great study from Pennsylvania called the Rosetta Study, showing that people are healthier within a group and had 50% less heart attacks. And that was in a group of Italian Americans who had a lot of social cohesion and spent lots of time together, had a lot of like family connections, and exhibited a lot of abilities to care for each other that were different from the average sort of disconnected American nuclear family. And that was found to be the only factor that seemed to be reducing their risk of heart attacks. Unfortunately, that population assimilated to the cold-hearted US way of doing things, and that heart attack benefit went away in a generation in watching that population over time. It's thought to be part of the Hispanic paradox, which is something where there's longer life expectancy seen in that particular culture, due most likely to having a stronger social network as a cultural norm. This is a picture of Tortola, which is really beautiful in the Virgin Islands, and I thought needed to be injected because I think this gets a little bit grim at times. Just to go into some of the neurobiology of what's happening with opioid use disorder, and how our brains work around all this. Addiction tends to work in three parts: intoxication, withdrawal, and then craving. So at first there's an experience of euphoria that is desired to be replicated, and that leads to an attachment to the drug. There's dopamine that is released, generally from the ventral tegmental accumbens to the nuclear accumbens. Oh, the ventral tegmental area, I apologize for that. And then here over on the left side, you can see these are natural reinforcers and how much they release dopamine. So in response to food, you get a little hit of dopamine. In response to sex, a little bit more hit of dopamine. These are things you're have evolved to do and be reinforced for so that our species survives over time. And then in response to heroin, like your brain receives a huge hit of dopamine. So that is part of what leads to behavior replicating that experience. And then the prefrontal cortex is the part of your brain that remembers things and starts to guide behavior. And so it remembers that you had that huge bunch of dopamine and then wants to do it again. The cycle of withdrawal that occurs is an experience of having a lot of glutamate in your system, which is the excitatory neurotransmitter, less GABA, which is the inhibitory neurotransmitter. I think I'm going to skip through some of the other details because I think this is not the right audience for it. And just go on to show that we do see similar findings in trauma with some changes happening in the prefrontal cortex. And that's where the changes develop, and you develop behavior to reduce withdrawal. And so generally what happens is the experience of addiction and continuing to use drugs is not trying to use them to obtain euphoria, but trying to use them to reduce withdrawal.
Dr. Brunner, what is NACC?
That's the nucleus accumbens. And so here it's kind of summarized that that's the reward circuit. There's a stress circuit, the amygdala and hippocampus. And then you can get this craving circuit through the orbitofrontal cortex and the prefrontal cortex. And like I said, I should have maybe deleted these slides out. It might be a little bit of the wrong audience, but I think it is a good thing to know that there are these well-known pathways in the brain that underlie addiction, like it's a very real physical thing that happens and develops, and that once that pathway occurs and develops, there's no like negative feedback loop, so you can't take that pathway away, but you can develop other pathways as part of recovery to try to mitigate the behavior and preoccupation. There's an extremely high incidence of PTSD in individuals with opioid use disorder. It's about a 33% rate of concomitant disease. And 92% of those with heroin use disorder have trauma, and even more patients with heroin use disorder have PTSD. One of the most important studies that I'm sure you're all aware of is the Adverse Childhood Experience Study, which causes a 7-fold increased risk of drug use disorders. It also causes changes in the brain that are similar to those seen in the brains of people with trauma, which include having like high corticotropin release hormone, which is shows increased vulnerability to stress and is part of why people get hyperarousal and have the experience of having their fight or flight reflexes triggered often and in a pathologic way that makes it really difficult for them to do normal activities, often without feeling incredibly stressed and like they need to run away as if from a tiger. Another cause of distress for a lot of people can be the insidious effects of social media. So I think this picture is a good example. This is when my family, I bought matching Mickey sweaters, and I had this like view in my mind of a perfect picture that we would take, and forestalled my family into it. But we were late to my daughter's ballet recital. My middle daughter is afraid of Santa, so she was like terrified. My son was actually super happy. He was like the one happy person, and my husband was really not very happy about wearing a giant Mickey sweater, and I think he hid it somewhere in our house because I've never been able to find it since this day. But you know, I thought this was a great picture and put it up, and it seemed like we were all having a great time, even though the inside story wasn't quite like that. So I think it's a good example of just how we all try to put up this perfect front and, you know, curated life, when our interior life can be really different and the real story is a little bit different. There's already a lot of impact of climate change on our mental health, and actually, according to a poll per Yale and from 2015, only 4% of people think we will be successful in doing something about climate change. So it's, even though 2/3 of people think it will harm future generations. So really a demoralizing picture for what that looks like in people's mental health. There's also a rising culture of perfectionism, especially in Australia, the US, and the UK. And this has been found to be associated with clinical depression, anorexia, and early death, and correlates with depression over time, as well as suicidal ideation. In terms of opioid use disorder, the criminalization associated with the war on drugs and the trend towards prosecuting suppliers of drugs to be prosecuted for murder, even when it's two people who are using together and one of them overdoses and ends up in the hospital, and their, you know, significant other overdoses and dies. So they're already traumatized by that experience, and then to be traumatized more by then being prosecuted for murder and potentially locked up for the rest of their life, when they're not quite like a drug dealer as much as just someone using and having moved into that life for that reason. It doesn't seem like something that really adds much to society to pursue people in that way. And often the relationship between the accused and the victim, that's what that graph is that of family, friend, or partner rather than a traditional drug dealer. That's in cases where the person was being prosecuted for murder. Other experiences are just being locked up in general or losing loved ones to overdose death. Another factor, which I think probably you all can relate to, is just the idea that we have a culture where like the easy fix of just taking a medication or having surgery and whatever is fixed often is what people will go to, as opposed to like a sustained lifestyle change. So moving into the more hopeful aspect of things, how do we solve this crisis? There is a lot of hope, so I just want to make sure to say that. I think this talk can sound really grim, but it's not meant to. One thing that is incredibly helpful is to move into a culture of trauma-informed care. So an organizational orientation that realizes that there is a very prevalent trauma, recognizes that that comes from neurobiology and also influences the illness and needs to be addressed concurrently with opioid use disorder. And also focuses on strengths, is aimed at being positive and acknowledges adapting to what the patient needs. And then that should really be present from the very first patient encounter and incorporated into every aspect of care. It's also really important for everyone involved in the organization to be educated on this. So that includes like front desk staff. And I know something that I feel really blessed and grateful about is that my my like coworkers at St. Joe's and everyone from the front desk staff to the MAs to the nurses are all really passionate about treating patients with addiction, and so they don't ever treat them like they're less than or judge them. And that's just a really important thing to have pervasive throughout the culture, because the patient's being judged by the person scheduling their visit, they're probably not going to show up to the visit. Increasing access to med-assisted treatment for opioid use disorder is incredibly important. It has been shown to treatment with buprenorphine has been shown to reduce the risk of death by overdose by over 50%. Unfortunately, there is a lot of lack of access to treatment, and a lot of people who don't want to be treated, often due to misinformation about one drug being substituted for another. Another way to do this is to improve access through emergency rooms after unintentional or intentional overdose, which is happening a lot around the city area, but I think something that really needs to be worked on to improve access in the outstate area. And I think it's important to consider admission and treatment as if someone is having a heart attack. That's what a STEMI is. I apologize for putting that in there. But often patients will be just reversed with Narcan. Well, often in the past, not anymore, they would just be reversed with Narcan, sent home, and given a phone number, which is not a very effective way to treat someone, and not at all what we would ever do with a heart attack. Non-fatal overdose has been found to be a really potent risk factor for death subsequently. So after an overdose in an emergency room in 1 year, there was a 5.5% mortality rate. So remember, it was 2% with people in general with opioid use disorder, so it goes up by a lot. And the highest risk period was actually in the first 2 days, with the median age of the patient who died being 39 years in that particular study, which came out in 2019. And so that, 2-day period, that's something that really could be mitigated by being admitted to the hospital and started on medication-assisted treatment. Adverse childhood experiences predict opioid relapse, and trauma-informed care can reduce it. There was a study by Dara Finko showing that in a rural medication-assisted treatment clinic, there were relapses in 54% of patients, with 34% relapsing after their first visit. With every adverse childhood experience, the odds of relapse increased by 17%. However, for every visit attended at that clinic, there was a 2% reduction in the odds of relapsing. Increasing insurance coverage is important. 18% of the patients treated with opioid use disorder are uninsured, and 38% have Medicaid. Increasing access to naloxone is also incredibly important. There was a Surgeon General warning to recommend carrying naloxone. Would recommend anyone on this training who treats patients, or just anyone in general, get a naloxone and carry it, especially on airplanes, although none of us are going on airplanes right now, but in the future, you could save someone's life. And it's possible to get over the counter in the state of Minnesota. A recent report from the CDC showed only 1 in 69 patients prescribed opioids were also prescribed naloxone, which is definitely not a high enough proportion. Another thing we can do is appropriately staff clinics and make sure that all our treatment providers are obtaining, enough support and compensation that they don't need to see too many patients, so they feel so that their care decompensates by the end of the day. So this was a study that was really interesting of 678,319 primary care appointments done by 5,603 different physicians. Their care was analyzed, and it was found that if the workday progressed, as the workday progressed, the physicians were more likely to prescribe opioids if their appointments were behind schedule or if they were late in the day. So those are things that happen very commonly in primary care, and they're predictable. So by the end of the day, those patients would receive opioids more often. However, prescription of physical therapy or like ibuprofen were not seen more often. So there was obviously some sort of psychological factor occurring in that situation. This is my son catching snakes. He says he's the garter snake king because we seem to have like a den of them outside of our house. And since we're doing homeschooling right now, we have chose science class to be him catching garter snakes outside of our house. And I think it's really cute. Another thing to do to reduce death is to reduce access to firearms. So these, all these guns came from one person's house. And I don't think that this is actually politically charged at all. It's just based on science. So the American Academy of Pediatrics makes it clear that having guns in the home is dangerous for children and causes risks, and recommends that we talk about it with patients at well child visits. As clinicians, it's our job to teach patients facts and cut through propaganda. And even the VA in 2019 released a suicide reduction algorithm that recommends restricting firearm access in multiple places. And just to, reiterate, that's in veterans who have training in how to use firearms. And those are the people, they're still recommending to take away and restrict firearm access. There were over 6,000 veteran suicides from 2008 to 2017. So suicides now actually exceed combat deaths for causing deaths in service members. That's why that recommendation and algorithm from 2019 from the Annals of Internal Medicine was made, and it's a pretty good one if you have time to look at it. Firearms were the method of suicide in 70.7% of the male veteran suicide deaths, and that's why they recommend taking them away. So thank you so much for bearing with me through all of this talk. I really would be happy for any questions to anyone who has them, and also to hear about any kind of access issues that anyone is having with addiction issues for their patients. The American Society of Addiction Medicine, we're having weekly meetings from doctors around the country just to check in on patients maintaining access to addiction treatment and what we can do to try to help with that. So if you're running into any particular problem, please feel free to let me know, and I'll see if I can bring it up in that forum or provide any support. So I'm open for any questions, and thank you all so much.
Thank you, Dr. Brunner. Can you hear me?
I can.
Okay, thank you. We do have a few questions here. So Peter asked, going back to the suicide discussion a little earlier, would you predict an increase in suicide events in this current environment?
Yes, I think that that is predicted by the American Psychiatric Association and their any event where there's a lot of trauma can trigger that for people. So definitely providing as much support as possible for people is really important right now.
Thank you. Devin says, this is a simplistic way to state it, but can you speak to the prevalence of relapse when someone comes off of methadone?
There's a high prevalence of relapse. So I believe that studies range from 70 to 90%, but it's definitely a really high risk period of time unless you're being rotated off to Suboxone, which often happens as well, and is, you know, that would be a reasonable thing to do. And patients deserve the autonomy to be supported in whatever they're choosing to do, but it is really important to be aware there's an incredibly high risk of relapse during the period of coming off methadone.
Thank you. Savannah says, in reference to MAT, what medication is the best or safest at treating opioid addiction since so many medications can be habit forming?
So that is, I would say, one of the things that can be confusing about that subject, because both Suboxone and methadone are reinforcing. So Suboxone acts as a, and I keep saying Suboxone, I really should be saying buprenorphine, which is the actual generic name of the medication. Buprenorphine is a partial opioid agonist. Methadone is a full opioid agonist. They're the most effective, and they're the ones that are proven to reduce the overdose death rate. So they're probably the best ones to use. Methadone is also proven to reduce hepatitis C, HIV, and crime rates. Well, buprenorphine has not necessarily been studied for all those things, but probably also does those things. Buprenorphine is a lot easier for people to use because it can be provided in any office of a doctor with an X waiver, but you do have to get a special 8-hour training to be able to prescribe it, so not every doctor can prescribe it. That's why there have been access issues with being able to provide enough people that medication. Methadone can be problematic because you have to get it from a methadone clinic and you have to go in every day, but that's probably the most salient, effective medication. Vivitrol or extended release naltrexone is an opioid blocker that's also available, but doesn't have as much evidence at being able to reduce mortality and protect from overdose death. So really needs to be used with the patient understanding that caveat to its use. So it used to be actually pushed a lot by justice systems because they really liked the idea of giving a once-a-month shot that did not have any habit-forming potential, but actually the company Alkermes that makes Vivitrol got sued recently because of their advertisements about it, because what they're claiming about that medication is not backed up by facts. So that was kind of a long answer, but essentially it boils down to methadone and Suboxone or buprenorphine are probably the two that are most effective and best to use in most patients.
Thank you. So does going on MAT generally mean you'll need to take it for the rest of your life?
So great and sticky question. So I was just reviewing the American Society of Addiction Medicine just released their new guidelines for treating opioid use disorder, which took away any time limit for using these medications and basically implies that you would use them for the rest of your life. And I would sort of put it in the perspective of chronic disease management. So when we treat people with hypertension or diabetes, you know, we get them stable on their medication and then we generally keep it going. So we don't say, okay, now your diabetes is really well controlled and now you better be on diet control and let's move to that and take away your insulin because otherwise we're going to have a moral judgment about you. So I think we're really trying to move addiction medicine into that paradigm, which is that once you're stable on the medication and doing well and your life is getting back to normal and you're working and your relationships get back to normal, like, we don't want to take the support that got you to that point away.
Could you hear me, Dr. Brunner?
I couldn't just now, you were muted.
Oh my gosh, I'm so sorry.
Okay.
What do you suggest for treatment of pain for individuals who have an opioid history?
So in general, I think the best treatment in that situation, and every person deserves like individualized assessment and treatment. I think that's a really important paradigm to apply to our population that hasn't always happened. So just doing like an individual history and physical and treating like the specific patient. So it depends on what the pain generator is. Sometimes there's some sort of specific fix or underlying cause that we can identify and treat. But if not, if it's chronic centralized pain, buprenorphine can actually be very effective for that. And I worked for a couple of years with a great mentor in Michigan who runs a pain and addiction clinic where he treats a lot of patients on buprenorphine for chronic centralized pain. And I have a few patients like that now. And it works best then as divided doses given every 4 to 6 hours, and generally at smaller doses than what we treat opioid use disorder with.
All right, thank you so much. There was one more question, and I'm gonna connect you with one of our viewers afterwards. So Rebecca, please, I will connect you via email. I'd like to thank you all for joining us today. We hope you have a safe, happy, and healthy weekend. We hope you are socially connected. And on behalf of the Center for Practice Transformation, we'd like to extend an extra special thanks to Dr. Emily Brunner for sharing her time and talents with us today.
Thank you so much. Thank you guys very much for being here. It was a fantastic experience.
Thanks again, and have a good weekend.